Thank you very much. Very encouraging to see a full house in a January morning rather, through the cold wave. Very distinguished panel of openers, and unlike cricket, not just two openers, but three openers. And three very different perspectives. Dr. Madan Gopal from Niti, Aayog, Ms. Aparna, who is at the front lines of action in Uttar Pradesh, and Dennis Curry at the UNDP, which is part of the both international as well as the development partner context. And on a lighter note, unlike perhaps most in the room, we do not represent the industry. Okay, so with the overall theme of mapping the future of healthcare, this particular panel is called India's Digital Health ID Mission, the Blueprint and Beyond. Starting with Dr. Madan Gopal, who represents the Niti Aayog, what really has been the vision of this mission, and tell us about the journey so far.
Okay, thank you, Rajib ji. So, when we started, when the focus was shifted from healthcare, now we have moved from health to wellness to well-being. That shift has happened. When we moved towards that, initially it was the primary healthcare approach. Now we are having comprehensive primary healthcare approach. And apart from that, having to move in that direction, one approach was the comprehensive primary care. Then as a signatory to universal healthcare, then we should be having some financial protection also. So we started from there. That means for rolling out that, we initially had two schemes, one which was Ayushman Bharat Health and Wellness Center and Ayushman Bharat PMJ. When PMJ started, at that time, when the software was being launched, I had to give the narrative, otherwise you won't be able to appreciate the journey of digital health. When the software was launched, at that time, you talk about any program, the TB program, you are having one portal, malaria program, you are having one portal, RCH, HMIS, that so many portals were there. And work was going on. So, but was happening in silos. And the ministry was working in that direction. And all the programs were there. Suppose I am a person, my data is collected for TB, for immunization, for every other thing. But all the data sets were not talking to each other. When the PMJ program was launched, we thought that we should be having a stack in which all this program data of a particular person can be talking to each other. So we came up with the concept of National Health Stack. The stack was released in the public domain, and based on the stack, our committee was formed. And the committee made a report which formed the basis for National Digital Blueprint, which has been rolled as a National Digital Mission. The National Digital Blueprint has all the elements of the building blocks for digital architecture of the country. It talks about federated architecture. It talks about what a digital ID would be there. It talks about how an institution can be this. So that with a single digital ID, we can have all those other things can talk to each other. Simultaneously, parallel activities are also going on in the ministry. That means they have an integrated health information platform in which all the other program would be riding subsequently. But essentially, for them to talk to each other, they require an ID. And this digital ID mission would be a journey which would be enabling them so that this cross-talking of the programs can happen. So we are moving in that direction. The architecture is there, blueprint is there, and all set.
So as a follow-up question, who are the technology partners who actually help craft this?
It's basically, we started with, there are many, it's not that this kind of major work can't be done in silos. We have to take the help of many people. I can't be naming, but there are many partners who are involved in designing this. But essentially, it was the NIC and the team from Niti and the ministry, and we have invited many other stakeholders. After that consultation, it mainly this digital blueprint was made by the experts which are from the institution with representation from a few of the industry partners.
Thank you. Ms. Aparna U, you head a team at Uttar Pradesh, one of the most challenging states by all accounts and measures. Tell us about the experience at the operational level.
I just want to give a little bit of an introduction to UP. Everybody thinks UP is a very massive state and very difficult to operate, which is true. But UP has also been a pioneer and forefront at many other innovations, whether it is at field level or even at IT. जो अभी हमारा MCTS application की बात करते हैं, it started as a pilot somewhere in UP. So what I want to state is there are many operational difficulties, mainly because of the scale and the digital divide. There is an urban-rural divide, and within the rural also there is a huge digital divide within UP. So that's one major operational difficulty that we face. Apart from that, the huge scale, we have like 22 crore population. I think we must be counting 24 crore plus. But the COVID vaccination program during the COVID times has actually shown the way of digital health in UP, because we have seen the entire state come together on a COVID platform, and as of now we have given 35 crore, 36 crore doses on the COVID platform, which at one time was thought inconceivable within I think a small gap of just 1 year's time. There have been many applications that have been running in the field in UP also. But as of in the last 2 years, this drive has intensified. And if I can just say a few statistics, in UP as of now, we have created more than 2.8 crore ABA IDs, which is almost 9.3% of the total ABA generation in this country. We have facility applications that have been verified, 15.86%. Facility applications received is around 15%. We also have total HPR 7.2%, health record links 7.19% of the total state. So UP has been doing a lot of tremendous work in this ABDM mission that we are talking about. But when we come down to ABA ID generation, there is challenges at the level of grassroots level, because as of now, awareness among the masses of a digital ID, health ID, and how it can translate into digital health records and how it can interoperable among various facilities, various platforms, is still inconceivable to people. So trying to convince people that there is a digital ID that you need, there is a health ID you probably need, and you need to get yourself Aadhaar registered if you're not, and then create an ABA ID is a challenge at the grassroots level. How we have been trying to arrive at it, how we are trying to deal with it. UP has, first thing, we have created a huge digital ecosystem. Thanks to some of the major programs like ECRP2 and some of the state-funded programs, we have been able to create digital, shall we say, infrastructure in almost 16,000 facilities, including the health and wellness centers. We have distributed 1.7 lakh smartphones to ASHAs at the frontline level. We have distributed around 19,000 tablets to our ANMs. We have distributed around 18,000 laptops to our CHOs. So basically now our frontline force is geared up with all the IT infrastructure that we can possibly conceive of. We have also come up with our own community primary healthcare application, eKavach, which is our own homegrown application. Right now, we have around 8.87 crore family members enumerated, 2.17 crore families which are already enumerated at this primary healthcare level, which is 38% of the estimated population of UP. And around 1.24 crore children under the age of 5 years, which is 44% of the estimated children for routine immunization. I want to mention this because we are doing a focused campaign on routine immunization in UP for the last 2 months, and we are aiming at 100% immunization by the end of December 2023, plus MR measles elimination round that's happening. So this is of core importance for us that all the eligible cohort of the children are enumerated. So that we have this huge database, out of which we are creating ABA IDs too. So ABA IDs take a little time because we need to take the consent, There's an Aadhaar-based process. So all this takes time, but we have managed through this application alone generating more than 18 lakh ABBA IDs in the last 3 months. So that's a huge task that we have achieved. Now, how we are going to use this ABBA IDs, how we will start generating electronic health records, that is to be seen, but we have already started at a nascent stage. We have rolled out the e-Shushruth platform in all our district hospitals and CHCs, community healthcare facilities. And this is in the process of, various process of go live, which I think in 6 months' time we should be able to cover all the facilities. And we have already started the process of electronic health record generation in these facilities. All our health facilities are already EHMR compliant, and I think UP is the first state, is that nationally we're at the national level, we're at the first position in this regard. Community level awareness we are trying to do through various platforms like our Mukhyamantri Aayog Mela. We have launched the Nikshay Divas, which is on 15th of every month, where TB and integrated all the diseases elimination round. We have integrated Nikshay Divas that has been launched on the 15th of every month, where actively ABBA IDs are being created. Plus, we are creating the health facility records during this process. So UP is very well geared. Our biggest challenge that we are facing now when we are going in this full throttle is our shortage of manpower that we are facing. That also we are trying to resolve through contractual recruitment drives which are going on, and we have been recruiting 25,000 plus workforce in the last few months. So you can say UP is in a very happy space right now. Question is how this health information is going to exchange between each other. For that, we have also recently come up with a unified surveillance portal that is going to be shortly launched, in which all this data coming from the various sources, CPC application, e-Shushruth, private labs, various points of entries that we are going to get this data, is all going to be pulled up into one unified surveillance portal, where we can then start exchanging this information seamlessly among the portals. So I can conceive of the day where the Asha does her survey में she identifies who are all the family members. एक family में एक pregnant woman could be there could be an anemic woman, there could be a person suffering from TB, there could be someone with high grade fever, there could be a dengue patient in the same family. And they will all be enlisted by the Asha. This information is seamlessly relayed to the higher facilities. Treatment is sought, and this treatment and the outcome is also relayed back into the Asha app, where she can then do the follow-up action. We also hope going forward there will be a higher level data analytics, which is the third phase of this whole program. When all this data aggregation happens, there will be a higher level data analysis, and we can predict in the future going forward where our hotspots will be, where we're going to encounter outbreaks, and we're already in the nascent stage of doing that. During COVID, we have already done that. And I think UP was the first state to come up with its own homegrown application for COVID surveillance. So we are hoping to move ahead in phase 3 on that. So I think UP is doing right now good work.
Thank you. That's a very impressive journey. And since you ended with COVID, Mr. Dennis Curry, you represent UNDP, which has been a very valued partner. So in some senses, COVID-19 has been a watershed in digital health, not just in this country, but world over. And the UNDP has been a very key partner in that process. So what really are the key takeaways that we can learn from the COVID-19 experience as far as digital health goes?
Thank you. And a real pleasure to be here this morning. I think that's the right word, watershed. You know, I think running up to, or before the pandemic, you know, there was, you know, a lot of work, you know, a lot of already kind of high predictions around what digitalization would do to health, you know, and the Internet of Things, when people spoke about digitization of the things in our daily life, you know, healthcare sector was always among the highest, around 40%, even with predictions by 2020 that healthcare sector would dominate that new technology. And that includes things like wearables, like we all have, many people have smartwatches now that track their exercise, but also more advanced medical equipment that really leverages all that digital technology. And of course, then with the pandemic, it really accelerated all that, and that is a global phenomenon, not just in India. So everything happened extremely quickly. We were all, in a sense, forced to accelerate our efforts in that, ranging from telemedicine to vaccine delivery and health systems more broadly. And then in terms of UNDP's story of our engagement in that, we have been a very privileged partner in India, very privileged to have worked with the Ministry of Health and Family Welfare centrally, but also with states, including UP and all states around the country, the health missions at that level on supporting health. And what was notable, was the leadership that India displayed early in this technology. So from 2014, if I'm right, decisions taken to digitize the vaccine supply chain, and that is the area that UNDP has been working directly in. So early work on EVIN. I myself was in India briefly in 2018, and I saw the EVIN program at that point, already hugely impressive, working in a number of states before full national scale-up. But yes, in India, decisions taken to digitize the vaccine supply chain, and then huge efforts into that, training 50,000 public health workers. And as I say, UNDP, we were proud to be part of that, and that was supported by the Gavi, the Global Vaccine Alliance. But then when it came to the pandemic and that watershed moment, I think that investment, that decision by India, that leadership that it had shown, really paid off, because when the pandemic hit, India already had significant experience of this digitalization, implementing population-wide vaccine infrastructure. And UNDP was, we partnered with the ministry, and that period was extremely intensive to get the CoVIN system up online, and that has become the backbone, the digital technology that we see in the CoVIN system. That has become the backbone to, I think, the world's largest vaccine drive. So it's something that India is rightly very proud of, and that UNDP has been very happy to play a part in. Other parts were also notable. Telemedicine saw a steep rise. Again, once the pandemic hit, I think we saw a 30% drop in in-person appointments in that year, but a 300% increase in telemedicine online. And again, I think the readiness to be able to do that was what was notable. So, I think looking forward, it's really important, and it's so great to see why conclaves like this help, keeping that momentum, bringing together the ideas, making sure we avoid silos in our approaches, and sharing the practice. And India's G20 presidency this year has also got off to an excellent start. The working group on health meeting this week in Kerala, and these issues really woven through. India has offered CoVIN, the technology, as a global public good, and I think that global leadership, from the perspective of the UN, when we work across the world and we support this kind of knowledge exchange globally, it has been really welcome to see that leadership and that sharing of knowledge that India has stepped forward with, and especially this year in G20.
Thank you. To come back to Uttar Pradesh, if I may put it delicately, UP has had a very layered experience with many of these large-scale health initiatives and programs. So given the complexity and the very large numbers of both human resources as well as beneficiaries involved, how do you see trust as an issue on the ground?
Actually, that is a very good question you asked, because at the very start, when in one of the discussion I was raising this issue, that people are extremely suspicious of technology. And I will not say this just in the rural areas. Urban too, people are very suspicious, because as you can see, there's a lot of awareness too in the field that there is a personal ID that's being created, that your ID is getting linked to your bank records, and there is linkages to across various platforms. And what if something goes wrong? I remember when, I think during the COVID experience itself, we were trying to get the registrations done. So I think Aadhaar was the basis of which one of the registrations happening. I remember this doctor who refused. He said, I'll not give my Aadhaar number. It's linked to my bank account. What if someone hacks it? So it took a lot of, I think that was for the vaccine delivery, the storage, the vaccine delivery that was to happen. So this is a practical problem that we are facing. So then we could not force him, so we had to get somebody else to get his Aadhaar. So, but the fact remains that in the field, people are extremely suspicious, and getting their support is a challenge. And it also cuts in a different way. There are also people who are totally unaware, to whom we need to make them aware and then take their consent. Because we need to understand technology cuts both ways. See, there is one extremely aware cohort who doesn't want to comply because it is very suspicious about privacy, and rightfully so, we should know where our data is going. There is also the other cohort in UP at the grassroots level who are totally unaware of the technology and what benefits it can give and what pitfalls. So we need to educate them, take their consent proactively, because that is where the biggest challenge in ABHA is. We need to take their consent. The consent needs to be an informed consent. So that's where the biggest challenge is, and that's where the journey has been slow so far. But I'm very happy to say that with this launch of eKavach, community level application in the ASHA smartphones, ASHA being a community health worker from the very village, she has a trust, at least supposed to have the trust of the village, and she does. She's a major leader in the village. So it's much more smoother for us collecting data or creating an ABHA ID than if we were to do the same thing in various other platforms or at the facility. The problem seems to be the urban areas. Again, urban areas, because our outreach is very less, at least in UP, I can't say for other states, and convincing the user about creating his ABHA ID. This has been another challenge in the urban areas. Urban area demands its own strategies, and we are soon coming up with our consumer interface centric app and linkages through which we hope to get the beneficiaries or get the citizens on their own to register themselves and create their ABHA IDs, which is also one of the building blocks of ABHA.
And from the UNDP's point of view, what measures have you seen that are effective in encouraging trust?
Yeah, absolutely, yeah. Very important and really good. I think what we have seen is measures that we can take that complement this in terms of the technology we use and how it's designed. And we like to say that it's incorporated trust or privacy by design as well, right in there in the technology from the very start to ensure that is kind of clear and visible, and people can be assured, both the individuals as recipients of healthcare and healthcare workers. But on workers, I think that is the key. The workforce being absolutely the first essential component of rolling out any system like this. It requires acceptance and adoption by health functionaries within the system. So training has been absolutely central in that, in our approach on EVIN and COVIN, and we're of course moving towards the next system of UVIN, the universal program of vaccination. So even though we focus and we speak and we talk a lot and we spend a lot of effort on the technology side, the training side is absolutely essential, and doing that at all levels, national, state, regional, and district levels, to make sure that we have the capacity. And I think with that training also comes some trust building as well. So the systems, in a sense, are only as good as the people that we have to operate them. And even in terms of budget, when we manage our budgets, we see that we spend more on training and capacity building of people than we do on the technology that underlies the system, and that's completely natural. That's the way it should be, in a sense that we are focusing on the essential people of that run the system. Another point I would connect to trust is the issue of inclusion. So as Ms. Aparna mentioned, certain different groups can be affected differently in terms of their understanding of technology and their perception of it. So one great aspect of the approach in India has been the the prioritization of inclusion at all levels. And that really is central or links to the spirit of the Sustainable Development Goals of leaving no one behind. So, and you can look at that from different angles, whether it's from rural and urban and taking into consideration the challenges of rolling out technology in rural areas. So the systems and the applications have been designed specifically to be resilient in low bandwidth networks. So it's not a heavy technology system on the smartphone application. But also, in terms of the focus on the patients and the beneficiaries themselves, ensuring that the system is flexible in terms of people may be arriving for vaccination without identity cards, so you can register on in person as well as online, and more than one registration can be done on one phone, so one healthcare worker can register multiple people, and also specific outreach to groups like LGBTI individuals. So the system and the policy in India has really been proactive in pushing inclusion, and I think that also has been really crucial in building that trust as well. Yeah.
Thank you. Dr. Madan Gopal, to come back to you and to the big picture, how do you see the digital health ID mission actually linking and contributing to the universal health coverage journey?
Rajiv, as everybody knows that we have reached around 25 crores, creation of 25 crores ABHA IDs. But how many of these ABHA IDs are being seeded for electronic medical records? That's the key. It's hardly 2%. That means a long journey to go. Because if you go way back in 2011-12, when we have enacted the Clinical Establishment Act, which mandated that all the healthcare institutions would be having electronic health records. The journey started from there. And ultimately, it's the seeding of the ABHA that's the key for this, and we are moving in that direction. If you look at the health structure in the country, at the district level, at the block level, you are having an institution which is known as community health center. Below the blocks, you are having sectors and the sections. The sector headquarter is your primary health center, and the section headquarter used to be the sub-health center. Now it has been upgraded as health and wellness centers. The data is coming from that level, and you are having a health volunteer, the community health volunteer, who is known as ASHA, at all the villages. We are having around 1 million of ASHA workers. And they have been now tasked to generate the ABHA ID and seed it into the records, because the program is collecting information. Once the seeding happens, then all the data would be talking to each other, and now we can run analytics and other things. Till such time, if the ABHA seeding happens, we have to see how we use the data. The challenges are there. So we have to see that how this seeding happens, and more upscale is happening. Second thing is, in the digital mission, you are digitalizing the healthcare providers also. We are creating an ID for the healthcare providers as well as the institutions, so that the data rights at the local level at the institution, and if the permission is given, it can go to the National Health Authority or the State Health Authority. That kind of mechanisms have been created. But the prime important thing is creation of ABHA IDs. As we all know that we have used the Aayog Setu app for creation of our vaccination, for scheduling our vaccination. If we have scheduled our vaccination using Aadhaar, automatically an ABHA ID has been created for them. So that means creation of ID is one thing, and using that ID to make it more meaningful. That means seeding that ID for electronic health records and using that electronic health records across all the platforms. That's the challenge, and we are moving in that direction.
You are someone who is in dialogue with all the states. And what do you find are the barriers across, or the common barriers across the country in this process of seeding?
One of the common barriers is the use of this, because we have to at least push that key. It is quite useful. You take the example of fintech revolution, how it has happened. When it was launched, people were not aware that how it is going to revolutionize our payment mechanisms. Now everybody, even the vegetable vendor, he's very comfortable using that the app, the UPI app and other things. That kind of confidence has come. But one of the important thing is how to train these people, the state people, in at least appreciating the use of this ID. Creation of ID, they will create crores and crores of ID. But how to use this ID, the challenge is seeding this ID into the data. And we are still struggling with that. So one of the major challenges, seeding this ID into the records, for which a lot of push is required. Because as Madam has pointed out, that the manpower shortages are there. That is across all the states. Are we using the manpower for providing services or for collection of data? That's the question which we have to ask. Even after digitalization of all the things, 40% of the time of the health workers goes for data collection. If the technology is not easing their workload, that means we have to find out a different way. If you are able to answer this thing, then you will find a lot of speed into the digital mission and other things. Otherwise, you want to have a high-end quality data at your level to a person who is low qualified, not having much exposure, not tech savvy. That person is collecting data for you and you are expecting a high-end, high-quality data at your level so that you can run AI and other things. As a result, what happens? 40% time, as I mentioned, goes for data collection. And how to address that thing, that's a challenge. Apart from that, there were spending capacities also. The state needs to spend with that issues and the challenges, the administrative and the governance issues have been addressed. Now I think you will see a lot of speed into the implementation of the digital mission.
You made some very important, pertinent points, and my question to Ms. Aparna U is therefore as someone in the leadership position, how is UP addressing these tensions? These are very genuine tensions.
As I said, we have already started addressing it, and UP is very proactively working on this. What he raised this issue was the frontline workers spending 40% of their time in data collection and data reporting. In UP, I think it's more than that. Because if you see earlier, before the CPHC platform eKavach came in, what used to happen is, there used to be only one ASHA community level worker in each village, but we are having multiple programs and none of the programs talk to each other. As NHM, I myself lose count of the number of programs, and recently there's been one more national program on snake bites. So we have one more, national program added to it. So I think COVID left, I guess we don't have a national program on COVID. But anyway, so now the point is, what is happening to all these programs is, at the start of every program, so if we start the year with routine immunization, the ASHA goes and does a one-time survey of all the family records and does a survey, enumerates it in a physical ASHA diary, and every month she updates it. So she does a survey for routine immunization. Then there is another survey that is done for the TB program. There is a survey that is done by the filaria program by the same ASHA, same house, same family. And she does this all multiple times in multiple programs, and you will see all the surveys will probably not agree with each other. So how is that possible? So what we have come up with is, we have come up with a comprehensive primary healthcare application, which we, for simple recall, we call it eKavach. Because we started it with the RA program, so its Kavach is a shield for the child from the vaccine preventable diseases. It's called eKavach. So what we do is, we do a one-time enumeration of all the households, which is basically literally the VHAR, which is the ASHA diary. After this enumeration is done, the updation is very easy. And whatever entries she has to do, because upon this is a layer of various modules. Modules of the ANM, which is a RA module, the Ramancha module, we have a TB module. There are different modules which will be used by different caregivers at various point of time, but the base is the enumeration of the ASHA. Once this is done, all the modules, only ANM has to done entry drop down. There is no entry by the ANM. Agar aap dekhenge, aaj ki date mein you have the HMIs and RCH portal. The whole issue is why we are not able to do it, at least in UP, there are states which have done very good progress in this, is because of the lack of, user interface which is a little friendlier. We have the Anmol app, ANMs are doing it, but again, pushing it is a difficult task because ANM बहुत entries करती है अपने level पर. So once this enumeration is done by the Asha in her mobile, nothing needs to be done. It is just a drop-down approach by ANM and by various health caregivers of their different programs. Now this e-Kavach is being integrated into various other platforms. We have a Mantra online MIS dashboard, which we have done 90% enlisting of all the delivery points in UP, which is almost 5,000 delivery points across UP. And we are getting 80 to 85% of data of deliveries real time on Mantra. So why this data is so important? Because earlier, if you wanted institutional deliveries data, it used to come like 2 months later on HMIS, which was not line listing, which was again numerical and that too not complete. So now I have data at my disposal, which is real time, which shows me across the 5,000 delivery points, how many deliveries took place in the last 24 hours. Let's say there is a lapse of data entry 48 hours. How many of them are cesarean? How many of them are normal? How many were maternal complications? How many stillbirths? How many maternal deaths? How many referrals? Because unnecessary referrals बहुत होती है. Emergency में ही referral, they don't even admit the woman. बहुत सारे referrals होती है. How many referrals? How many of them came through 102? How many the beneficiary was forced to get her own delivery, transport? How many of them were given blood services in-house? Because we do have BSU units and blood banks, but often we get this complaint that the beneficiary was asked to get blood from outside. How many low birth weight? This is rich data which is helping policy makers across various departments like ICDS, because ICDS takes data from us, how many low birth weight babies we need to. We have got requests from the CRS people, census people, ki please let us know how many actually births have happened so we can at least get them registered. Now we are thinking of getting this integrated with the CRS portal so that real-time birth registration happens. Now this data is getting linked to our e-Kavach. So community level data is then pushed into our facility level data portal, and then we can think of various real-time processes, GSY payments. अभी तो GSY पेमेंट 3-6 महीने में होता है. इट्स अ रियल फैक्ट, जबकि ये 48 घंटे के अंदर होना है. तो वी कैन थिंक ऑफ अ रियल टाइम पेमेंट ऑफ GSY थ्रू दिस ऐप, थ्रू a payment interface like Beam. So these are the things, interesting things that we are working out in UP. Like you rightly said, once this data is 100% complete, but we have enough data to start away, we are doing it, we can do a higher level data analytics to predict which areas anemic women are, because this CPHC application starts from maybe enumeration of the eligible couple. So we are thinking of starting from there. Eligible couple, get the anemia, get the woman tested for anemia. Anemia is a big problem in UP even today, even though we were the first state during NHFS 5, probably the only state which has decreased anemia by almost 3-4 points, while the rest of the country has increased its anemia. But still, anemia continues to be a problem in UP because 50 to 60% of pregnant women are bound to be anemic at some point of time or the other during the 9 months of pregnancy. So we can predict how many, which regions, which geographical locations, where are the home delivery points. So this kind of data analytics, not just in areas of maternal child, but across all the communicable diseases, NCDs, this is going to be a very rich data, which we can think of a higher level data analytics. So I think UP is very much on its way.
Dr. Madan Gopal, to come back to you on this note, each state would obviously be very enthusiastic in making different, taking multiple approaches in this journey. Now, from a national perspective, how does that enable this journey, and to what extent does it complicate the journey if there are multiple, or I wouldn't say multiple, if there are diverse initiatives going on, given that this is one mission?
Rajib ji, is very challenging, because if you name a problem, next day or within a week you are having an app. That kind of, with so many multiple apps in the system, it's very difficult to standardize which kind of app is to be used for which kind of thing. But the solution is slowly, as we have done with the fintech, the health tech will also take it. The moment ABA IDs are there, even if that ABA ID is seeded into the app which the person is using, and that data can be used afterwards. That's in the future's perspective. But it's very challenging because if you talk about a software, if you take why the uptake of this the hospital information software has not happened, where it was envisaged in the clinical establishment way back in 2011-12, that all the hospitals would be having software, and that would be facilitated by an agency, central agency. And whole of the country had a snowbird CD so that the standardization of data collection was there. The country had a snowbird CD license for all the hospitals, irrespective private and government. That license was there, but the uptake was not there because the standardization of the software could not happen. Because as an hospital, if I'm using a software, I'm very comfortable in using that software. You take the example of PMJ. PMJ has rolled out the second version of the software. How many states are using that software? The uptake and acceptance of that software is a different thing, but we can have a common consensus, and that common consensus is the digital ID, the ID for the hospital, ID for the providers, and seeding that ID into an electronic record. So that irrespective of many apps, any program, if you are having these basic three things, I think all the programs will be talking to each other.
So talking, since you mentioned common consensus, what perhaps is the underlying consensus on what exactly to leave in the realm of the states, and how much or what aspects are at the national level?
Because if you look at the federated structure, the health is a state subject. We have always been talking about that. Once it comes to public health issues and other things, then the center takes a responsibility. Otherwise, it has to be done as we are doing beautifully in the National Health Mission. Now with National Health Mission coming into the fold, and we are trying to see that how the continuum of care can happen with the involvement of ASHA workers for seeding of the ABA IDs to the electronic health record. That means that momentum has started. Now the states are on board. States would be moving in that direction with the involvement of the National Health Mission. Because that's a major program, the major flagship program of the government, and with the involvement of them, I think you will feel a lot of momentum into that.
Thank you. As we come towards the end, Mr. Dennis Curry, perhaps the last question to you. How do you see a digital health ID mission actually linking and contributing to the SDG goals and agenda?
Thank you. I think, we very often in India, in the UN, broadly here, we often say that, if India succeeds in the SDGs, the world will. And I think it's not just, I think the starting point in people's mindsets when we say that is perhaps, India's size, and its population size. But it's not only that, and I mentioned earlier India's G20 leadership this year. And if I point to that, not just in health, but across the agenda that India has brought to the G20, to its G20 presidency, when you put that alongside the SDG framework, they are really integrated, across so many areas, including environment, health, education, lots of areas. So India has really shown great leadership on this, and so it's also not just by bringing India along in terms of development, but also working with others also. And in health, then, similarly, I think India's stance on this, the offering of its knowledge and experience of what we've heard today, the complexity of rolling out public health policy like this in a country like India, with its federal structure and the diversity of its of the country in terms of language. We talked about so many things. So that experience is really, so valuable internationally. And it has been great to see India reaching out to share that proactively and internationally. I think but also the technological learning as well. These very complex challenges of how do you, in the one hand, support the innovations and the leadership that will come from state level and even down in district level, and so that those kind of practices, the learning we see, for example, in UP and other places, can be brought together and into an integrated whole. So that's why I think the repository of health information is another great example, as you said, comparing with the learning from the fintech sector. We now have this backbone of a registry of information where that innovation and that ground level driving of policy and work can be integrated into a whole that brings it together. And in the work that we do in even in CoVIN and now in the pilots on UVIN, it's very much integrated. So I think, if I'm right, the CoVIN app has been generating a lot of the unique health IDs for individual patients just by virtue of people coming for the COVID vaccination, is feeding in the information into this central system. And then, of course, the other points of data, the health professionals registration and the facilities registration as well. So I think that has been great to see. I think that's a great learning that can be exported as well, about how a central system can connect with and integrate with others. So yeah, I think in maybe a couple of final points, the open source nature as well of the technology and the, so it has been developed in the knowledge of sharing, with that from a starting point. And when we work as well, we are ready to, UNDP likes to phase out of our work when our support is done. We work very closely with state and national systems to make sure that their capacity is there to take on what we have developed together. And certainly in terms of information, we do the same, making sure that the software is open source, but also that the information we are generating in these systems is compatible and can be link in and be handed over to these national infrastructures. So in general, very optimistic, huge lessons from India for the world on health that will certainly contribute to SDGs globally.
Thank you. That leaves us with a few minutes to take questions from the House. Open for a discussion. Any questions? And please ask your question and please address it to the person you would like to ask to.
A very good morning, madam. This question is to Aparna, madam. I had worked in the UP territory, and that too in the health domain for a short while. I was in a senior general manager of National Institute for Smart Government, currently vice president of consortia. Madam, my question is, with so many initiatives that are being rolled under NDHM, and if we look at the core issue, that is like if you visit any hospital or any other infrastructure, the challenge actually lies on the capacity side of it and not on the technology side of it. Like if you look at doctors, they are surrounded by huge swarm of patients. Either there are no data entry operators, or the way the data entry is being done, that is creating a lot of data errors also. So do you really feel that while we are digitizing, the data error issue or non-availability of data can also pose a huge problem to this?
See, there are a lot of issues in health service delivery. We're not just talking about technology. If you talk about physical health service delivery, it's possible that a person can walk into a facility, doctor may not be available. Doctor may be there, but there may be huge queues. He's not able to get through. But these are not related to digital per se. But because we are here on a digital platform, I restricted myself to the digital this thing. Otherwise, if you see health service delivery ki jitni bhi whatever issues, that is mammoth. We can't deal with them. But the point about data, you're perfectly right, because we had this experience of e-hospital, that NIC platform which rolled out in 32 hospitals. It has not been very pleasant for us, because one time aapne software to dal diya hai, we've trained one time. After that, the hospital is left to fend for itself. They have no idea what to do with that data. They have no idea what to do with that, with the system in particular. And to what extent is it helping them? For the doctors, it's an additional cumbersome thing, so much so they've left it out. So the only thing that is happening is that the OPD data registration is happening. But you must remember, at that time, we didn't have this concept of ABDM, right? So now what we are trying to come up with is a holistic approach under the health digital health mission, where there is a unique ID, there is an interoperability, and it is no centralization. Like Abhi, you said, what is the challenge of different data systems? They'll all be united under the ABDM, but they will run decentralized. Ultimately, a decentralized method, at least as far as UP is concerned, we can say an organic method where the data systems are growing organically within the community, within the system, is probably a far flexible system than getting a rigid system from outside and then imposing on a top-down approach. Because if you see HMIs or RCH, There is nothing wrong with them, but it never got its acceptability because there is no user friendliness. If today the आशा और ENM entry कर रही है, उसको लग रही है ये column ऐसा नहीं होनी चाहिए, ये column ऐसा होनी चाहिए, इसकी ज़रूरत नहीं, उसको ही होनी चाहिए, she can't do anything about it. So this is a problem. So what we are trying to come out with is a data system which is very flexible, user friendly and grassroots level approach. So the e-Kavach system that we are coming up is very much flexible with the ASHA. It has been created with the ASHA, ANM and the comprehensive primary health care system feedback, and it is a process which is still getting, it's a work in process. Every day we're getting new feedback, every day it gets quickly amended, quickly addressed, which could not have happened with a one data system driven. Coming to e-hospital, now we are coming up with a system e-Shushrut, which is again CDAC, but we are now going to link it across with our e-Kavach and different other platforms. So what happens is, when you have a community enumeration already in your system, so a person with an ABA ID, with his data already in the system, enters the hospital, all the hospital has to do is fetch his ABA ID, everything comes down. So actually the manual entry of data is something that we should do away in a due course of time, once our enumeration is 100% complete. So the issue of data errors, mismatch, I feel should by and large, seep away. Halaki, that is the ideal thing. Technology being technology, there will be people who can't read the technology. I can understand the initial days when we got these computer systems installed in the primary healthcare facilities. Someone calls up and says, my computer is not working. So it's not like your computer is not working. So we realize it's not plugged in the first place. So these things happen. So these are things that will always be there, which will be effectively dealt with proper capacity building, which is very rightfully said, plus efficient troubleshooting system. We should have help desk. We are planning for help desk in every district, every block. A troubleshooting system where an ASHA can call up and get immediate redressal. Because you have to understand, technology needs to be friendly. Even now, if you see all the apps on your phone, you use those apps which are useful, which are friendly. You will not look at an app which is difficult for you to operate yourself. So we have to understand ASHA coming from a very different background, being the cutting edge. All the data gets fed from the ASHA and ANM level, right to the top level. So we need to see that the technology is user-friendly and flexible, and she should know where to ask if she has doubts. I think with these three things in place, with a proper capacity building and awareness and sensitization, it should not be difficult for people to adopt to it. Already ASHAs are swigging, and ASHAs are doing, book my shows. So why shouldn't, and I assure you in UP, our hartals and union activities are organized through WhatsApp. So why not this?
Okay.
Thank you, ma'am.
One or two more questions, Max.
Good morning, everyone. I'm probably the odd one out. I'm from private healthcare. So a very, very happening discussion. Very happy to know this. I've been part of the initial launch of, ABHA, etc. So my question is, what is the plan for integrating private healthcare? Me as a consumer, I was very excited to know about HABA, but when I go to hospital, I don't know how they get integrated. Where are my records?
Okay, let's take the other question.
Thank you.
Well, this is almost an extension of the capacity building in the healthcare system. I represent the private sector of healthcare delivery in UP. I'm practicing for the last 45 years as a physician. Ma'am, I find that there is a vertical divide between the private and the public health sector. Why don't you take us on the board and immediately your capacity building multiplies jumps by 20 times, 25 times. Now that in UP the era of white ambassadors and lal battis and red tape is gone, please take us on the board so that we can also help in the building of the healthcare delivery in the state.
Okay, Dr. Madan Gopal, can you address the private sector issue in a generic sense?
Okay. If you look at the pilot of NDHM when it was launched, so it was launched in the UTs, wherein the private sector hospitals were also digitalized. The doctors in the private sector, because it's work in progress, after the digital IDs are created, it is to be seeded into the electronic health records. Then that electronic health records would be used. It's work in progress. In the coming days, you will be seeing a lot of things. After having successful successful experiences in the pilot, then it was upscaled to whole of the country. That means we are moving in the next step. In the coming days, you will be seeing a lot of things happening in the private sector. In the fintech area also, it has not happened in 1 day or 2 days. It took us 2 years to see that happening, in which every other people are now using the fintech technology. Similarly, in the health tech also, you would be seeing a lot of things happening. In the private sector also, how many of us are having ABA ID now in the room? If I ask, the answer would be negligible, because we are not aware that we would be having an ABA ID. Have we created an ABA ID for ourselves? No. You ask yourself that, are you having an ABA ID for yourself? If you have used Aadhaar for your immunization, the COVID immunization, obviously that data would be there and you would be having an ID for that. That ID would be seeded into the electronic records, and that record in the coming days, if you go to an institution which would be having a scanner for using that information with your consent, then that use can happen. Still, a lot of work is to be done in that direction, and work is in progress in that direction.
Thank you. Ms. Aparna, very quick answer, please.
Yeah. I'm very happy first and thankful to you. You've declared the red tapeism days gone in UP. But as far as the private sector is concerned, like I said, the issue of trust, government and private, the issue of trust is still a very big issue that needs to be crossed. Second, private sector participation in government programs have been very minimum. For various reasons, Clinical Establishment Act has not been properly enforced in UP. It's still in progress. Regulatory mechanisms need to be in place. That is in progress. It will be intensified and strengthened. Secondly, I think we need to create more awareness in private sector. You could be probably a very progressive representative, but often private sector say बहुत ज़्यादा participation भी हमको नहीं मिलता है for various reasons. Maybe they don't want their activities to be part of public scrutiny. They feel that their data may be lost. They may feel that government may do surveillance on their activities. For whatever reason, this has been one challenge. But I think another challenge has been also capacity of the private sector to maintain these records digitally. Because there may be a few health facilities which are on the higher end having a host of computer operators and receptionists. But the smaller clinics have a challenge of manpower again. They have a challenge of keeping their paramedics intact and then hiring an extra resource who will keep all this data intact, enter various records at various places also has been a hazardous task. But I think with the way we're coming up with portals and applications which are user-friendly, so I think we should be able to cross this bridge.
Okay. Thank you very much. A very big hand to a very distinguished panel and very frank discussion. Thank you very much.